Excited to introduce our presenters. We have Brittany Goodrich, Director of the Kennedy Willis Center, and Michelle Banks, Educational and Outreach Specialist at the Kennedy Willis Center. And with that, I'm going to pass it over to them to take it away.
Thank you. We're just going to pull our screen up to share and we'll get started. Okay. Well, it's great to see you all. Thank you so much for spending your lunch break or, the early afternoon with us today. We're going to spend the time together talking about aging and dementia in adults with IDD. So some of the learning objectives or things that we hope that you'll take away from today's presentation is to first be able to define and understand the difference between normal aging and pathological aging. Next, we're going to review some strategies and supports. And last, we're going to share some practical tips and resources with you. So just to do a brief introduction and welcome for myself and Michelle, my name is Brittany Goodrich. I'm the director of the Kennedy Willis Center. I've been in the nonprofit and human service field for about 13 years and provide independent meeting facilitation and consultation for families and service providers. Michelle and I are both Second Wind Dreams virtual dementia tour facilitators and are also affiliated regional trainers with the National Task Group on Intellectual Disabilities and Dementia Practices. Michelle Banks is the center's education and outreach specialist. She's had over 17 years of experience in the human service field, holding varying positions and responsibilities related to residential team leader, house manager positions, as well as time in the adult day service departments. She also delivers person-centered trainings and dementia-specific trainings. So a little bit more about the Kennedy Willis Center. We are located in upstate New York in Otsego County, and we are a resource center that provides best practices in the areas of training, research, education, and program development for individuals, families, and professionals in the disability community. So we're going to begin by talking a little bit about support across the lifespan. And the reason that this topic I think is so important to all of us is that life expectancies for individuals with IDD are increasing. On average, individuals with intellectual and developmental disabilities are living to about 62 years, and individuals with intellectual disabilities and Down syndrome are living closer to about 57 years. That data has probably changed a little bit. It came from 2019 data, so it's probably increased a slight bit, but this is really great news. In fact, life expectancies for people with Down syndrome specifically has more than doubled since the 1980s. So with increased life expectancies, we know that the level of care that's going to be needed for an aging person becomes increasingly complex. And there is a lack of knowledge and available resources currently, I would say, at a national and even federal level to meet long-term aging needs. With that lack of information and resources, there can sometimes create a crisis level situations for individuals and families and providers. So our hope is to work together to share information and share knowledge so that we don't get to that point and you have enough resources and information to help your loved one live and age successfully. So thinking about aging, it's a progressive condition, I guess, that we all go through as soon as we're born. Aging varies by person, and it is impacted by a variety of different things, including our genetics, our lifestyle, which may be our food and drink consumption. It might be the level of physical activity or exercise that we participate in. It may be how good we sleep. It also is impacted by things like our environment, where we live, we work, and we play. And lastly, aging is also impacted by our attitude. It is true that people who are happier live on average longer than people that aren't. So keep that in mind as you're living your life and you're supporting your loved ones. So I want to talk to you first about normal aging and some of those expected changes that are going to happen to all of us and to the ones that we care for as we age. There's going to be expected changes related to our motor functioning. That's things like having a decreased strength, decreased flexibility, maybe more pain and stiffness as we age. There's going to be changes to our sensation and our sensory Things like changes to our vision and our hearing. We may begin to need glasses or hearing aids or bifocals, things that we didn't need when we were younger. Our digestion can also tend to slow as we age. And we can have changes to our cognition, our memory, and our thinking. So while older adults can learn new things, that's absolutely true. It may just take us a little bit longer to learn those new things or new tasks. And lastly, aging can also have expected changes related to our reaction time or our processing. That may be things like for us, our driving and our reaction time when we're choosing to turn or to use the brake. It may be things like a delayed response to a loud noise. Or if we're trying to catch ourselves, if we could become unsteady, that might be a little bit more difficult for us to do or for our loved ones to do. So there are some challenges that are associated with aging. And when we think about pathological aging, these are changes that occur in our body due to age-related disease. And they are unexpected and they are not guaranteed to happen to us. Things like the development of chronic health conditions. That could be the development of cardiovascular disease, diabetes, or cancers. We may have more medications that are prescribed to us. So that polypharmacy, which is the prescription of multiple medications, can create risks for us as we age or our loved ones age. I just read an article recently where a person that tends to have more than 4 medications prescribed to them has an increased fall risk by 20%. There can also be risks for dehydration, just different risks related to the medications or the drugs in terms of side effects or their interactions with one another. And this is also complicated for the person and for their caregiver if we have multiple medications that we have to remember to take. So when we think about aging and changes to our brain, thankfully, developing dementia is not a given. It's not a guarantee. However, there are changes to our brain size and to the neuron connections as we age. As we go through our 20s, our brain is actually slowly decreasing in size. It's very normal. Those neuron connections can become a little bit interrupted and damaged as we continue to age, and the neurons are responsible for the way that we send and receive information. So older adults may experience some forgetfulness. We'll talk about some examples coming up. We may mix up information, and we may take longer to adapt or process new activities or information. So I wanted to show you, this is an image scan. You can see on the left is a healthy control, so what we would consider a healthy brain. And then on the right, if I say that right, unless it's backwards for you, we can see the Alzheimer's disease to the right. So you can see some of the changes that are happening to the brain. To the right with Alzheimer's disease, you can see there's more black. So the brain is decreasing in size. And then in the middle section, you can see the ventricle sizes are increasing. So we can see the atrophy happening. And we can also see some changes to the hippocampus, which is those bottom nodules of our brain, which is responsible for the learning and memory. So we've kind of worked through some of the normal aging. We'll summarize it at the end. But when we're starting to shift to think about dementia, dementia in general is an umbrella term and it's for a group of symptoms. It's not necessarily a disease. We'll talk about Alzheimer's disease, which is a type of dementia, but in general, dementia is an umbrella term for many different types of symptoms. They tend to impact intellectual functioning, things like reasoning, problem solving, and memory. People with dementia tend to have changes in their personality, their mood, or their behavior. And that is definitely true for people with intellectual and developmental disabilities. We tend to see changes in people coming out most in their behavior and their mood before we start seeing changes to their memory. Dementia needs to have symptoms, or to someone that has dementia, the symptoms need to be severe enough to interfere with daily functioning. That is not us forgetting something once or twice. That's not us struggling to make a decision a couple of times. It has to be something that is really impacting us or our loved one to get through their days successfully. The risk of dementia does increase with age, and unfortunately at this time it is a progressive condition and there is no cure. When we think about dementia and Down syndrome, Michelle and I just wanted to touch on this a little bit because the risk of developing Alzheimer's disease is much higher for someone with Down syndrome. And that's really because, at least what researchers have shared so far, is that the triplication of that 21st chromosome is carrying a gene that produces what's called amyloid precursor protein, or APP. So we all have the 21st chromosome, but individuals with Down syndrome most have the triplication. So that can lead to too much APP building up in the brain and causing the buildup of plaques and then other protein deposits, which are the tangles. And both of those together impact how the brain cells are functioning. Also, what's going on with someone with Down syndrome as they continue to age is that they're experiencing what we would call premature or accelerated aging. So they're aging quicker. So we're likely to see changes in someone's physical and cognitive functioning earlier. And for an example, a person that has Down syndrome that's 50 years old may be closer to someone who's aged 65 to 70 physiologically. So keeping that in mind, those changes that you're seeing, it's important to recognize. So ultimately, dementia is occurring earlier in the population of people with Down syndrome, and there is a high risk, over 50%, for developing Alzheimer's disease. So the next couple of slides just highlight some of the key things that dementia impacts in terms of our functional ability. So things like our memory. What we'll see is more often changes and inability to recall more recent events, conversations or things that happened, but the person is still able to hold on to those longer term memories that they have. We're going to see some changes to previously learned skills, including our language. Forgetting maybe the names of people or objects that are new to them. We're also going to see some challenges with our ability to focus and to pay attention. So difficulty concentrating, difficulty making decisions. We're also going to see changes based on a person's ability to reason and to make good judgment calls. An example that I like to share is if we look outside and we see that it's raining, a person with dementia may struggle to think, I should grab a raincoat or I should grab an umbrella. That would be a way that you and I would reason and make a good judgment call on what we should wear or something for the day. Dementia is also going to impact sensory. We talked a little bit about vision and hearing. But we do know that people with dementia are experiencing changes to their senses. They may have misperceptions or may misidentify things. For example, seeing something, a shadow, and thinking it's something else. Maybe it's a spider, or maybe it's something scary, which can lead to other uneasiness or changes in confidence because now we're unsure of what we're seeing and what we're hearing. Dementia also impacts our ability to sequence tasks. The classic example is making a peanut butter and jelly sandwich and all of the steps that it takes to get your ingredients, to open everything up, to lay it on the counter and make that sandwich becomes a little bit more challenging for someone. So when we think about helping someone that may be experiencing dementia or cognitive types of symptoms, breaking those tasks down to simplify the demands and can be helpful for them. So this slide is really just a picture, a couple pictures of some of those changes where we see, where we just mentioned changes in someone's previously learned tasks. So you can see to at least my left is someone who had signed in their handwriting starting in 1999, and by about 2011, it looks like you can see a drastic difference in the person's penmanship. So you can see some really nice cursive. It's very neat on the line for a few years. In the middle of the page, it becomes a little bit changed where you can see the person's now switched to writing in print. They're capitalizing things, and ultimately then they're dropping letters. And at the very bottom, it becomes a little bit illegible. The picture that we wanted to put up on the right is of an artist. He was doing some self-portraits of himself across the span where he ultimately developed dementia. And you can see at the beginning, wonderful skill that he had and how that changed over time. So I'm just going to summarize really quickly what we heard, and then I'm going to switch it over to Michelle. But when we think about the difference between normal aging and dementia, we know that normal aging, we may forget the names of people we don't know well. We may take a little bit longer to process new information. We may misplace items around the house, right? So that's us walking out, leaving our keys on the counter and we walked out of the door. We have to go back in, or maybe forgetting why you came into the room. Occasionally missing events or forgetting things, and occasionally having some difficulty finding words. But ultimately, you're able to remember and recall those words that you're looking for. Whereas dementia, we're seeing significant memory loss, especially related to recent events. Misplacing of objects in unusual places. So whereas you're putting the keys on the counter to walk out, that makes sense because the door is right there. We may be seeing things like someone's toothbrush is now in the kitchen drawer, or we're seeing maybe a food item or a kitchen item in the bathroom. Dementia can also create the inability to recognize or remember names of people that are close to them, which can be very difficult for families and loved ones, especially people that they've known and had a relationship with for a long time. And also people with dementia are going to see more increased confusion, and that can lead to agitation for them. I can't hear you.
How do you know you got dementia?
Say that again, Alex.
How do you know you don't have it?
How do you know if you're going to have it?
Yes.
Yeah, so, I don't think there's a crystal ball to know if we're going to have it. There is some genetic play involved. We talked a little bit, if you have Down syndrome or your loved one has Down syndrome, there's a higher risk there. But I don't think there's an actual, if we can guarantee if we know someone's going to develop that or not.
Okay.
Okay, can you hear me now?
Yeah.
Wonderful. All right, wonderful. Now we'll get into it. Sorry about that. Okay, so we're just going to go over some warning signs of dementia, and then we'll kind of get into it a little bit as to the process of determining if it's dementia. So some warning signs of dementia include things like unexpected memory loss. Again, like Brittany said, those more recent events. Difficulty doing usual tasks, so those things that people are used to doing every day, and maybe they're having some difficulty with that. Getting lost or misdirected, displaying some confusion in familiar situations, personality changes. As Brittany said, personality changes is really that place that we see it first for adults with IDD. Problems with gait or walking, and the onset of new seizures. So it's important to note that all of these symptoms need to be new symptoms, and they need to be severe enough to interfere with everyday functioning. There you go. So some behavioral symptoms that we will see throughout the disease. These occur across all stages. They include things like disinterest or withdrawal. So maybe, the person used to always love basketball, but now they're kind of shying away from it. Or perhaps the person is spending a little bit more time in their bedroom and just not being as involved. Personality and mood changes. So perhaps your loved one was super outgoing. They were always the center of attention. And now they're kind of, hanging back. Maybe they don't want to be in the limelight anymore, and they're just kind of just hanging back there and being a little more quiet. Agitation and aggression, especially in new situations. We'll see some sleep disturbances. So perhaps the person is mixing up their days and nights, or getting up in the middle of the night and believing that it is time to get ready for the day, and some paranoia and hallucinations, and we'll get into that a little more. So it's important to know all of those symptoms that I shared with you. All of them could be caused by something other than dementia. So it's really important that we engage in a differential diagnostic process so we can rule out all of the other things that it could possibly be. So there are a lot of conditions that can look like dementia. This could include things like nutritional or vitamin deficiencies. This could include sleep apnea. We're learning that sleep apnea is very, very common in people with Down syndrome, but underdiagnosed. So that's something that we want to pay attention to. Sensory impairments should be included in differential diagnosis. If I can't hear you, I may not respond to you appropriately. So that, is an easy fix. I can get some hearing aids, right? Depression is also something that can look like dementia. The hiccup here is depression is also very common in people with dementia. But the good thing about depression, if you can say there's anything good, is that it's treatable. Hypothyroidism can also look like dementia, and polypharmacy. So Brittany kind of talked about polypharmacy a little bit, but that multiple different medications and they could have different side effects that could look like dementia. It is worth noting all of these conditions that I've shared with you, they are all treatable conditions, and sometimes they can be reversed, whereas Alzheimer's disease, dementia, is not reversible. So we want to rule out anything that we can treat before we decide that it is something that is not treatable, like dementia. So the diagnostic procedure for this is we like to do baseline cognitive testings. We generally begin that at age 35 for people with Down syndrome, age 40 for people with IDD. We want to gather all of the information that we can. Of course, we want to look at the routine physical. We want some lab testing. We want to check those different sensory areas, so vision tests, hearing tests. If we can do some imaging, so an MRI or CT scan that can it can detect any lesions that are on the brain that could be causing changes in cognition. And of course, specialty consultations, so meeting with a psychiatrist or a neurologist or a gerontologist to help with this diagnostic procedure. So I talked about baseline screenings. This is the early detection screen for dementia, or the EDSD. It was developed by NTG, or the National Task Group on Intellectual Disabilities and Dementia. This screening was adapted from the D-SQUID to be more effective for people who live with IDD. The tool examines 8 different domains of function. So it includes the ADLs, or activities of daily living. It includes language and communication skills, sleep-wake change patterns, ambulation. It touches on memory, behavior and affect, adult self-reported problems, so the person is reporting problems, and again, any notable significant changes that are observed by others. This tool is not diagnostic. It is an administrative tool. So the tool can indicate need for further assessment if we want to determine causes for those changes. It can serve as a point of discussion amongst the team. It could serve as a point of discussion with the healthcare provider. And it should be completed annually and shared with the healthcare provider. That can be shared at the annual wellness exam, or if there are, a concern comes up, it can be shared sooner than that. The tool should be completed by the person's team. It typically does not include the person because it is based on observations. The tool can also help to determine if there are other things going on. So one example we see come up often is the sleep. So we may see a lot of what we call indicators. in the sleep domain, and maybe there's nothing going on anywhere else. So we look into that area and reach out to maybe a pulmonologist for a sleep study, and found out that the person just had sleep apnea. So we were able to treat the sleep apnea, and then those cognitive concerns kind of resolved themselves because they were due to the lack of restorative sleep that the person was not getting due to the sleep apnea. There's a lot of value in early screening, so it can assist in identifying those functional changes. It can help identify interventions or new supports beneficial to the person, so like that CPAP for the person who is experiencing sleep apnea. It can help reduce caregiver anxiety, so the caregiver knows that things are being looked at, so it can kind of help reduce that a little bit. And it allows the team more time to access available treatments, to plan for future programming, and to align the services and supports to meet the individual needs. So when should we use this? We should use this tool whenever there are observed changes in thinking, mood, or behavior that are significantly different than typically seen. It's worth noting, so as Brittany said, these should be symptoms that interfere with daily functioning. So it's important to remember that, we're all entitled to bad days. So, a couple of bad days does not necessarily mean that the person is experiencing these changes, but we can use the tool to help us kind of put that out on paper and determine if the changes are significant. As I said before, we typically begin at age 35 for adults with Down syndrome and age 40 for adults with other types of IDD. And again, we repeat these annually, or if there are significant changes before that annual, we can do it sooner than that. So what are some things that we might see, and what are some strategies or things that we can do? So some common behaviors that we might see in a person who's living with dementia, we may see some wandering, and by this I mean that aimless wandering. So the person, they're using this as a wayfinding tool. So the person is wandering around because they're not sure what they're supposed to be doing in that moment. So they wander around until something makes sense for them to do. Please don't try to stop a person from wandering. We can use it as a means of exercise, physical activity, and exercise is one of those key things that we can do to try to help slow the progression of the disease. So by all means, exercise as much as we can. Rummaging and hoarding, again, this is another wayfinding tool. So the person's not sure what they're supposed to be doing, so they rummage through things until they find something that makes sense for them to do. It can be helpful if you leave out tasks for the person to do, or leave out something that they can rummage through. So this could be as simple as leaving a pile of unfolded towels on the dining room table. Because what do you do with unfolded towels? You fold them, right? So the important piece here is it doesn't matter if it's folded the proper way. You can always fix it later, but it gives the person something tangible to do, something that is purposeful, so they can be helpful. We all want to have purpose in life. So if we can provide that in some way, no matter how small that is, it gives the person a sense of purpose and can help them to lessen their anxiety. Increased forgetfulness and repetitive questions. I understand sometimes, hearing that same question over and over and over again. You're like, oh, I just told you 5 minutes ago, but the person doesn't remember that you told them 5 minutes ago. So answer that question again. It can be helpful to incorporate the usage of some visuals or maybe some schedules. So maybe the person is struggling with their morning routine and knowing that they have to wash their hair before they brush it. So we can give them a schedule that, shows the washing before the brushing and whatever their morning routine is or nighttime routine. Crying, shouting, and aggression. Please stay calm, provide that reassurance. Know that these behaviors are a form of communication. So the person may be trying to express a need to you, but they're not sure how to do that, or they've lost that ability. So they will express it to you in the only way that they can, which may be yelling or some other type of aggression. Try to, this is where we kind of have to become a little bit of a detective and determine what that need is. Know that many times this may be a response to pain, hunger, or thirst. So offer the person that drink, offer them something to eat, maybe some pain relief. Unfortunately, people who are living with the disease are living in pain, unfortunately often, and may not have the ability to tell you that. As Brittany said, we lose some of our skills, including language. So they may not be able to find the word to tell you that they are in pain. So they'll do that in the only way that they know how. Paranoia and hallucinations. Please don't try to reason with the person. If they insist that Bob is sitting across the table from them, hello, Bob, how are you? Validate the feelings behind it. So, maybe Bob was a really important person in their life. So let's talk about some memories with Bob. Like, what was your favorite thing you did with Bob? The only time that these hallucinations really are problematic is when it's a bother to the person. So perhaps Bob is not a nice person and Bob is really bothering them and they're getting angry at Bob. It seems silly, but sometimes just asking Bob to leave can make all the difference for the person living with the disease. It can be helpful if you kind of make a whole physical thing about it. So you go over and you open the door and like, all right, Bob, time to go. Sleep-wake disturbances. Again, sometimes we can flip-flop those days and nights. Know that it's okay for the person to take a nap during the day or maybe sleep on the couch that night. Maybe their bedroom just isn't a happy place for them. Let them sleep on the couch. It's not going to hurt. Allow the person to wander if that's what they need at that time. It gets that exercise and hopefully might, help tire them out a little bit. It could also be helpful to restart a person's nighttime routine. So we all have that routine that we have before bed. Maybe it's, pajamas, brush teeth, straight to bed. Maybe they read a book. So restarting that routine at 2 a.m. or whatever time they're awake, it gives them the expectation that, okay, well, after I finish this routine, then I go to bed. So they're more likely to go back to sleep if you restart that routine. Resistance to or refusal of personal care. So try allowing the person time as much as you can. Maybe we're not going to shower at 6 o'clock. We're going to offer it again at 8 o'clock. Simplify the language and commands. So short demands. Try to lessen that to-do list. So maybe today, instead of washing our hair and our toes, we're only going to wash our toes today and we can do our hair tomorrow. It can also be helpful to set up the environment ahead of time. So making sure you have everything you need, all of that stuff is in the bathroom, the soaps, all of the towels, the clothes. Turn on the water before you get there, so it kind of warms up the environment. Music is wonderful, kind of set that mood. and really having everything set before the person gets there can be really helpful. And now I'm going to turn it back over to Brittany. She's going to give you some tips for holidays at home because we know that's coming right up.
Thanks, Michelle. So as Michelle said, I know it's hard to say, but we're at the end of October and the holidays are coming. So we wanted to leave you, these are our last few slides with just some helpful tips to have the best holidays that you can with your loved ones. Some things to keep in mind, and I'm sure you're already doing this, is to be proactive and thinking about any potential concerns. That could be something like thinking about maybe who's going to be at your family gathering or your friend gathering, and maybe who isn't, for whatever reason. Maybe you've lost a loved one over the course of the year. Maybe someone isn't able to travel or somebody's ill. And is your loved one going to be asking about that? And how do you set them up for success and to share that information with them in advance? Creating a safe and calming environment. If your house is anything like mine around the holidays, it can be very busy, very loud, very fun, but very chaotic. So thinking about opportunities to offer a smaller room if you have the space that maybe has a little less noise. Maybe you can leave out some preferred activities, things that you know your loved one enjoys, books, magazines, putting on a special movie, some puzzles. So if they want to spend some time or go over there to relax a little bit, they can. Also considering hosting a smaller gathering if possible. Again, if maybe it's not the 25, 30 people that you always have, and maybe you're doing a smaller holiday gathering with lesser people, again, to reduce some of the stimuli of the environment. Some other holiday tips that we thought would be helpful to share would be to try to offer direct questions with fewer choices. So an example here would be, would you like apple or pumpkin pie versus what would you like for dessert? With an open-ended question of what you would like for dessert, the person, again, may not have that language skill or the ability to say. I mean, they could still point, so that's possible, of course. But if you know your loved one always goes for that certain pie or that certain cake or dessert, and offering and limiting those choices so they can be successful, that's a great strategy. Obviously focusing and celebrating current skills and abilities and creating moments of connection, no matter how small. I think the example I gave earlier this week was maybe you always do something together, like you make a gingerbread house. Again, just as an example, maybe in years past, you've done everything from actually, baking the gingerbread to then decorating everything. And maybe this year, just to simplify, maybe that gingerbread house is already pre-baked and you've got it and you're just enjoying like adding the candy or adding the icing again, so you can have that time, especially if the concentration isn't there. And knowing that if your loved one is not able to travel, or for some reason you're not able to travel to them, or vice versa, using that video chat or phone call is always important. Taking time to ask if they're in a group home setting, maybe you're asking the staff or other caregiver what your loved one's plans are for that day, so you can share information back and forth and have a good conversation together. So we're just going to end with a couple of these slides, just wanting to acknowledge these services that are available by the Kennedy Willis Center to yourself as family members and your loved ones. There is an open call line, so that number is above. You will get a copy of this presentation, so you can call us. Michelle and I will respond to you in a couple of days if you leave a voicemail. You should also be receiving our biannual e-newsletters. Those go out in March and October. Various information. It might be information, latest research. It might be different programs or resources that are available to you. We can also conduct some of those baseline assessments that Michelle was talking about. So the ED-SD, I put the site into the chat. And again, we're happy to offer that to you. And we can do that virtually. We can come and do that in person for you if you would like, especially if you haven't used the tool before. We do a lot of foundational and specialty webinars such as this, and different resources and referral support for caregivers. Michelle and I have also attended some life plan meetings. Again, if your loved one maybe is experiencing some age or cognitive change and you'd like someone to be there, we're happy to attend. We can just sit there and be quiet and listen. We could also talk to some of the team of your loved one to offer some strategies for support. We can also do environmental site reviews of wherever the person is living or going about during their day, whether it's a day program or a workplace setting, to look at things like accessibility and safety. We also have, it's probably quite a far drive for many of you, but on the site of Pathfinder Village, we offer the virtual dementia tour experience. So that would be coming here way up to Otsego County, but you never know if you're in the area, we would be able to do that for you. And we also have a great partnership with Thomas Jefferson University and their occupational therapy program. If Michelle and I are really struggling with something to help you with your loved one, a challenge that maybe you're experiencing, we can ask occupational therapists that we know very well from Thomas Jefferson University to connect with your team and to help. Just yesterday, we started our new Lunch and Learn webinar series. It's on navigating changes of life, grief, and loss. Again, that started yesterday, but it goes the next couple of Wednesdays. If you are able to register, you're welcome to. It's at no cost to you. And if you register, we will be able to get you the recorded links. If you can't catch us live, you'll get the recording as well as an electronic toolkit of resources. We put in here some resources for you that just helped us build this presentation for you today, some things that we thought that you would find beneficial. When you get the presentation, feel free to navigate and check any of those out that are of interest to you.
I like you.
And that's all. That's just our contact information. Thanks, Michelle.